Thanks for having me. I think this is at least my third time talking at BACC. Last time it was virtual because of the pandemic, but I'm glad we're back in person. We talked last time a little bit about this, and I'm reprising the update. I think it's worthwhile doing it every few years because so many different treatments are now coming on board, which is very exciting for us and for all patients who have the unfortunate occurrence of having ovarian cancer. But this just shows you how active the research is and how much additional treatment options we have, and how the science is moving forward, and all the progress we've made in the field of treating patients with ovarian cancer. So first of all, the good news. These are the latest numbers from the National Cancer Institute and the CDC. And these are statistics that are compiled every year looking at both the incidence and then death rates from various cancers. On the left are the number of patients who are diagnosed with various cancers in the US in the year 2024, because this was published in 2025. And as you can see, breast is on the top, but ovarian cancer is nowhere on this list, the top 10. So it's way down there. It's like 20,000. It's a little bit lower than it used to be, so that's one of the good news about it. The death rates, though, are still quite high. As you can see, it accounts for about 4% of the cancer deaths in the US, but that's falling down and down. It used to be that ovarian cancer was the #1 gynecologic cancer killer in the US. It's no longer that, because uterine cancer is now taken over, which is an interesting development, and it has to do with how well we've been able to treat patients. This is another publication out of the National Cancer Institute. This is looking at both the incidence and deaths from ovarian cancer over time to see how well we've been able to either detect and treat, and the overall incidence of the cancer. And what you'll notice on the left-hand side is change year to year for various cancers. You'll notice that the incidence for many of these cancers has gone down. The most was for thyroid cancer, which has gone down almost 3% per year over the preceding several years. But ovarian cancer is right behind it. The incidence has gone down by more than 2% per year, which is very significant, and probably has to do with some of the lifestyle modifications, may have to do with the fact that fewer women in the age, during their menopause use hormone therapy. We may be able to detect patients who are at high risk for ovarian cancer, and these patients have risk-reducing surgery at a younger age, preventing them from getting cancer in the first place. Those are all things that could contribute to this. What's more important is, you can see on the right-hand side, and that's the real silver lining to all of this, is death rates from various cancers have been falling. And in the blue are cancer death rates that have been falling over time. In red, cancer death rates that have been increasing over time. The vast majority of cancers have seen their death rates go down. In particular, ovarian cancer, you can see it's one of the top 3 cancers that have gone down in terms of mortality over time. Melanoma and lung cancer are the top 2, mainly because with lung cancer, awareness about smoking and smoking rates going down, that helped a lot. Melanoma, it's because of breakthroughs in treatments, but same thing with ovarian cancer. We've been able to treat patients better, cure more patients because of all the advances we've made in the field. Okay. This is a slide that I've shown before. It basically shows you just the various subtypes of ovarian cancer. The ones that affect us the most are what you see on the left-hand side, high-grade serous ovarian cancers. This accounts for the vast majority of ovarian cancers that we see in the US. These are characterized by some important mutations that I will highlight here. I don't know if I have a pointer anywhere. Not that important. The P53 mutation is really key. It's one of the main steps that these cancers undergo in their development. You have to have a P53 mutations to develop these cancers. The other important mutations to highlight are the BRCA1 and BRCA2, because these are really key drivers for these cancers as well. This is a prototypical, unfortunate course for many patients with ovarian cancer because they are still, to this day, the majority of patients with ovarian cancer are diagnosed at a late stage. And many patients initially present because of symptoms, because we are not good at detecting patients when they're asymptomatic, basically to screen them and find the cancers before they start causing symptoms. And unfortunately, by the time symptoms set in, the cancer's already spread and the cancer's already advanced. So most patients unfortunately present with advanced stage. They often have chemotherapy first, followed by surgery, or surgery followed by chemotherapy. And these days, almost all patients get some sort of what we call maintenance therapy, basically medications to take after the chemo and surgery is done to prevent the cancer from coming back. But unfortunately, even with all of these aggressive measures, many patients still suffer from recurrences, which lead to more chemotherapy, potentially more surgical interventions, and ultimately, because once the cancer comes back, it's considered in many cases incurable, patients end up dying. This whole process at this point probably plays out over 4 to 6 years. Those are the average numbers for our patients. It's a lot better than, say, 40, 50 years ago, where the life expectancy was a little bit over a year for patients with ovarian cancer. Nowadays, we can stretch it out to 5 to 6 years because of all the advancements in the treatments. But this is the typical course for most patients. One of the key components of the treatment for ovarian cancer patients is surgery. And surgery is really key, particularly up front, the first time around. And it often involves removing the uterus, the fallopian tubes, the ovaries. We all have this fatty apron on the inside of our body called the omentum that hangs off the transverse colon. That's also a site of cancer spread for ovarian cancer, so we often have to remove that. Occasionally, we'll have to remove enlarged lymph nodes. But the key for surgery in advanced stage ovarian cancer is to take out as much of the cancer as possible, leave as little behind. So ideally, if you can get all of the cancer out, what we call a complete resection, that would be great. If you have to leave any cancer behind, we strive to keep it under 1 centimeter in size, which is about a third of an inch. That should be the size of the largest tumor you leave behind if you have to leave any tumor behind. The first surgery is the most important one, and this slide illustrates how well patients do the more cancer you remove. So in this, on the right-hand side of the slide, you'll see a graph where on the one of the curves, you'll see that there is survival in the number of months, and on the bottom is the percentage of the tumor being removed. And as you notice, the best outcomes are for patients who have 100% of the cancer removed, meaning everything that you could see or feel. And the patients do worse, the more and more cancer you leave behind, the less optimal the surgery is. So that patients who have only about 10% of the tumors removed, 90% of the tumor remaining, these patients do really a lot worse. And there's always a silver lining to all of this, and I want to encourage even my patients with stage 4 ovarian cancer to keep some hope alive, because even with stage 4 cancer, even with disease that's spread to the lungs, we can cure patients. I have many examples of this. This is one of my earliest patients back in when I was working at UCLA with stage 4 cancer, who presented with metastasis into the lung. We did a successful surgery with resection of the lung nodule, followed by chemotherapy and maintenance therapy, and she's still alive and well. Yeah. One of the advances I wanted to talk about, and one of the important things I wanted to lead in with, and I talked about this back in 2022, is what we call intraperitoneal chemotherapy. The bulk of the cancer in ovarian cancer is almost always inside the abdominal cavity. That's also where a lot of the recurrences happen. So for many years, we focused our attention on treating the cancer locally by delivering chemotherapy inside the abdomen, what we call intraperitoneal chemotherapy. Some of my patients have had experience with that, either intraperitoneal chemotherapy during their during their treatment course or intraperitoneal chemotherapy during their surgery. But the idea is you can deliver a high dose of chemotherapy locally where the cancer is to make it more effective. This is the result of one of the main trials that has supported the use of intraperitoneal chemotherapy. This was published over 20 years ago now. And in this trial, GOG 172, the outcomes of patients who had intraperitoneal chemotherapy were improved over patients who had regular chemotherapy. The problem with this approach is it's very toxic, and most patients can't even finish the treatments because of how toxic the therapy is when you give it intra-abdominally. There's a lot of pain, there's a lot of nerve damage, there's a lot of fatigue, there's a lot of issues with bone marrow. So we tried to refine it by changing the dosages, by delivering less of the medications. Unfortunately, it just didn't work. So unless you really hit it hard and left a lot of scars behind, the treatment stops working when you deliver it intra-abdominally that way. And it sort of made us more and more hesitant to deliver the treatment that way. So we've tried to refine it over time. And one of the refinements we've come up with over time is, well, we're operating on patients all the time when they first present. Why can't we deliver the chemotherapy at the same time? Because this was a successful treatment option that was used in other hard-to-treat abdominal cancers like appendix cancers. We've tried to adapt this approach to our patients with ovarian cancer. And this is where heated intraperitoneal chemotherapy comes in. What the concept is at the time of surgery, when you've taken out the cancer, deliver a dose of chemotherapy at that point to knock out whatever's left, along with heated fluid saline that's designed to sensitize the cancer cells to the effects of the chemo. And so what happens is you're getting surgery for ovarian cancer, you get all the cancer out. Then during that same surgery, you deliver chemotherapy inside the abdomen for a period of time along with the heated fluid, and then suck it all out at the end of the surgery. And so the idea behind this is mainly because we're already in the abdomen, we can deliver it right then and there, we can deliver heated treatment at the same time, but it's also less likely to cause side effects. You only do it once, you suck it all out instead of leaving it inside the abdomen and having all the side effects from this treatment. And patients don't have to come back and have to face all the issues of delivering the drug repeatedly inside the abdomen. This approach worked. This is a clinical trial that was published now 6 or 7 years ago. And in this trial, this is a group out of the Netherlands. They took patients who are getting what we call neoadjuvant chemotherapy, meaning they were getting chemotherapy first before getting surgery. And then at the time of surgery, half of these patients had the intraperitoneal chemotherapy given, the other half did not. And they compared outcomes over time. Well, the group that received the chemotherapy at the time of surgery inside the abdomen did better, both in terms of reducing the chances of the cancer coming back, but also the chances of the dying from the cancer overall over time. It added 1 year of life on average to these patients, which was sort of practice changing for us and made us try and offer this treatment to more and more patients.
Can I ask a really quick question? Does this treatment also work where you are unable to resect all of the cancers?
Very good question. One of the stipulations of the trial was that you were able to remove as much of the cancer as possible and leave as little behind. So the unfortunate answer is if you leave a lot of tumor behind, it doesn't work well because the chemotherapy doesn't penetrate as well, we think. There are other research opportunities in that space for patients who have a lot of tumor that can't be removed. But one of the stipulations for this treatment to work is that you've been able to remove as much of the cancer as possible.
I have a quick question. Can you ever use HIPEC for someone who's had one or two recurrences?
That's another very good question. Unfortunately, the best time for this to work is upfront.
Okay.
The data for using it in the recurrent setting is controversial. There are some trials in Europe that showed advantages and trials here in the US that didn't show a difference for patients, so it's very controversial. What's pretty clear is that in the upfront setting is probably when you get the most bang for the buck work with this treatment.
Okay.
I have a question. You showed a screen earlier that showed that if 100% of the cancer is removed, then the person has 40 months to live. Is that for all grades and stages?
This is so. I've used an illustration. This is an illustration from one of my mentors for a study from over 20 years ago. This is prior to all these advances we've shown over time. It's not a contemporaneous study in terms of outcomes. It's just an example. These are, this is a time where really all we had was some very rudimentary chemotherapy and then surgery, showing where chemotherapy was very important. Now, you can argue that for a lot of our patients with modern therapies, we've been able to move the needle a lot more, and chemotherapy really has become much more important than surgery, so to speak. But it just shows you the importance of the quality of the surgery. The more you remove, the better. Even now, with our modern treatments, the less you leave behind, the better patients do. The numbers may not apply as well, but it's just an illustration of the importance of leaving as little as possible behind. This slide goes over one of the important concepts in the treatment of ovarian cancer. The reason chemotherapy works so well in ovarian cancer is because it can damage the DNA of the cancer cells. Now, in normal cells, after you get damage from chemotherapy, normal cells have a mechanism where they can repair their DNA. They could basically heal themselves and get over the insult of the chemotherapy. Ovarian cancer cells don't tolerate that very well, particularly if they have a defect in something called the homologous recombination pathway. The homologous recombination pathway is a mechanism by which normal cells can repair themselves. And key components of that homologous recombination pathway are the BRCA1 and BRCA2 proteins. And many ovarian cancers have a defect in that pathway, which means they're very sensitive to chemotherapy because they cannot heal themselves. So when they get damaged with chemotherapy, these cells die off more quickly, okay? And this is very important because we noticed that a large number of our patients, about 40 to 50%, have something wrong in that pathway, in that homologous recombination pathway, either a BRCA1 or a BRCA2 mutation, but also a series of other mutations in that pathway itself, and it confers this, what we call homologous recombination deficiency. Okay. Why this is important, there's a class of drug that's really become a key component of the success we've seen in treating patients with ovarian cancer, and these are PARP inhibitors. The PARP protein, the PARP enzyme, is important for DNA repair. It is one of the mechanisms that normal cells use to repair themselves. And it's one of the mechanisms that keeps cells healthy. So the idea here is we found chemicals that could block this protein. And the idea is you have a double hit on these cancer cells. These cancer cells, a lot of them have these defects in the homologous recombination pathway. If you target another pathway that these cells use to repair themselves, you can induce more and more damage, and more of these cells die off, okay? What we call synthetic lethality. These drugs prevent the cells from being able to repair DNA damage and inflict more and more damage on the cell itself. What ends up happening is when you're using a combination of these drugs and chemotherapy, you're more likely to be successful because these cells have defective pathways to repair themselves. Okay. And where this is really important is in maintenance therapy. Maintenance therapy is a concept that has developed in ovarian cancer over the past, I would say, decade and a half. We've for many years tried to explore ways of preventing the cancer from coming back, but we only have been successful in the past 10 to 15 years. And it's mainly relied on this new class of proteins or new class of drugs that target these proteins. We started out by using this in patients with recurrent ovarian cancer. So as I alluded to before, recurrent ovarian cancer is very hard to treat. Many patients are going to die from their cancer. Unfortunately, we can't keep these patients on chemotherapy just forever. At some point, we got to take a break. And then when we take that break, what we used to do was just wait basically for the cancer to come back. What maintenance therapy did in that situation was do something while we're waiting. And these are 3 different trials, SOLO 2, NOVA, and Ariel 3, where patients who had recurrent ovarian cancer and had BRCA mutated cancers, either because of patients having a BRCA gene mutation or the tumors having a BRCA mutation. And these patients, after they finished successful chemotherapy, were placed on these drugs, on these oral drugs that target this PARP protein, what we call PARP inhibitors. In SOLO 2, it was olaparib, Lynparza. In NOVA, it was niraparib, Zejula. And in Ariel 3, it was rucaparib, Rubraca. You'll see the curves all look the same. And the bottom curves on each one of these figures are patients who were taking the placebo pill, nothing, the sugar pill, because that was the standard of care. You just watch and wait. The top curves are patients who actually took the active agent. And you can see that outcomes for all of these patients were similar. The time off of chemotherapy, the time to the next progression were basically multiplied by 4. Your odds of reoccurring were significantly lower, 70% lower, of dying or progressing on these while you're taking these medications. And that impacted outcomes for patients over the long term. Patients lived longer when they started taking these medications. This is that same SOLO 2 trial. And as you can see, we added a significant amount of time to these patients. The average time by which patients recurred is typically about 6 months, and patients usually survive for a year or 2 after they recurred. But we added another year of life to these patients, so it really made a difference for them. This is another slide looking at the same class of drugs, but in the upfront setting, so in patients who were first diagnosed with ovarian cancer. And this is where really the breakthrough came. This is a slide looking at patients with advanced stage ovarian cancer. These are patients with stage 3 or more cancer who had a BRCA mutation and were placed on the drug. You'll notice that, and the survival is on the bottom, so at 7 years, so 84 months, 2/3 of patients were alive when they took the medication. This was unheard of, and we've never been able to achieve this level. And what was really important is if you look at this, more than half of patients were alive with evidence of recurrence at least 5 years. So these are patients who are basically considered cured, because at that point they stopped taking the medication. So we were curing more and more patients. So this was a huge breakthrough. And we were able to see that regardless of the drug. This is the same curve, but for patients who took Zejula and patients who took Rubraca. Same results over and over again. So it really made a difference for these patients. I'm going to skip a couple of slides just because of time. These are some important breakthroughs for patients with reoccurrence of their ovarian cancer. We've for many years relied on chemotherapy to treat patients with recurrent ovarian cancer, and mainly platinum-based chemotherapy, carboplatin, cisplatin. But what happens when people become resistant to chemotherapy? This was a very hard nut to crack. Many of these patients had a very short runway and not a lot of treatment options. But over the past 5 years, we've had big breakthroughs. One of them is this drug Elahere. And Elahere is an example of what I call targeted chemotherapy. The way these chemotherapies work, or these targeted treatments work, is they are a combination of an antibody that targets the cancer cell. The antibody recognizes a specific protein on the surface of the cancer cell. It is combined with a payload, a smart bomb. When the antibody attaches to the cancer cell, it penetrates into the cancer cell and releases the chemotherapy. So it's like a targeted treatment, a targeted smart bomb that goes directly into the cancer cell and delivers a lethal dose directly into the cell itself. Elahere, which is mirvetuximab, targets this protein called folate receptor alpha, which is highly expressed in ovarian cancer cells and nowhere else. And it delivers this chemotherapy directly into the cancer cell. And there were a couple of trials that basically showed that this was better than traditional chemotherapy for these patients, added more years of life to these patients. The quality of life is a lot better because it's much more targeted, fewer side effects. This was so successful that we're now exploiting this pathway more and more. This is the next generation of drugs targeting this same folate receptor alpha. This drug is called Rina-S. It's in development, but it's likely to become a very important part of the treatment options we have for patients with ovarian cancer. And once we've established that they work in like hard to treat ovarian cancers, we start moving it up. So we may be able to see it in lieu of traditional chemotherapy even. Another very important drug that's been a big breakthrough in many different cancers, Enhertu, is a drug that was developed for breast cancer, but it works for gastric cancer, ovarian cancer, uterine cancer, cervical cancer. As long as these cancers express this protein called HER2, the drug finds that protein, delivers the chemotherapy directly into the cancer cell, and kills off the cancer cell. It is very effective, particularly if you have high levels of this protein called HER2. And in ovarian cancer, the response rates in hard-to-treat cancers were 40 to 50%. Typically, response rates in hard-to-treat cancers are considered successful if you can hit 20% response. 1 in 5, that's considered successful. Half of patients responded or more. This is big for us. Finally, we talked last time about immunotherapy. There's been some advances with immunotherapy. We just published, a group out of Europe published the results of an immunotherapy trial that's been one of the only success stories in ovarian cancer and immunotherapy, and it's using traditional chemotherapy plus immunotherapy. People may be familiar with this drug called Keytruda. It's a big blockbuster drug that Merck sells. It's used in a myriad of different cancers, from melanomas to lung cancer. This is the first clinical trial that has been successful in using this drug in ovarian cancer. In this trial, patients were randomly assigned to chemotherapy alone, typically in this situation, paclitaxel or Taxol. The other half of the group got Taxol plus Keytruda, and it looks like the addition of Keytruda improved outcomes for patients. This was particularly interesting for patients who are interested in immunotherapy. There are other successful options for immunotherapy in ovarian cancer. This is a trial that I really like, looking at almost a chemotherapy-free option. This uses Keytruda plus bevacizumab or Avastin, which is not a chemotherapy. It's designed to block the blood supply to cancer, and an oral drug called Cytoxan, which is a very light chemotherapy. People use it a lot in rheumatoid arthritis. And it's a very well-tolerated immunotherapy combination that's been pretty successful in many patients with ovarian cancer. Another important update here, and this just shows you how the field is exploding in terms of our options. This is likely going to become one of our other treatment options for patients, especially for those patients who don't qualify for these targeted chemotherapies or immunotherapy. What if you don't have that folate receptor alpha? What if you don't have that HER2 protein? What if you can't get Taxol, or what if you don't tolerate the pembrolizumab, the Keytruda? Well, this is another option. It's called relacorilant. And relacorilant is an interesting drug. It blocks something called the glucocorticoid receptor. People know cortisol or these stress hormones or glucocorticoids. All cells have that, and apparently glucocorticoid receptors in the cells blunt the effect of chemotherapy. If you can block these glucocorticoid receptors, you can enhance the effects of chemo. The drug has to be very specific, unfortunately, because if these drugs are indiscriminate, glucocorticoids are very important for the function of our body. We need it for stress response. And if you block it everywhere, it can really shut the body down. Relacorilant is very specific for cancer. And so what this trial has done is combined glucocorticoid with a drug called Abraxane. It's another form of Taxol. And the reason they chose Abraxane is because you don't need to take many patients. I don't know if you've been on chemotherapy, but many patients have to take Decadron prior to chemotherapy to prevent nausea and side effects. Abraxane is one of the only drugs where you don't have to give the Decadron, and Decadron will interfere with relacorilant, so you have to pick a drug where you don't have to use the glucocorticoid like Decadron. And in this situation, Abraxane is combined with relacorilant. This has also improved outcomes for patients, both in terms of the risk of recurrence, but also adding more time to patients' lives. This is the result of a Rosella trial that was published about a year ago. Finally, this is one of our sort of points of pride here at Stanford. We've invested a lot of effort into immunotherapy at Stanford. The approach we've undertaken at Stanford is what we call cellular immunotherapy. So Keytruda is a drug that basically activates the immune system. The approach we're using at Stanford is different. It's called cellular immunotherapy, and in this situation it's called CAR T cell therapy. You may have heard of it. It basically uses your own immune cells to fight the cancer. The way we do that is we extract these immune cells called T cells from your bloodstream. We then train and change the immune cells in the lab to attack ovarian cancer cells, and then we infuse them back into the patient so that they can then attack the cancer. These are various examples of CAR T cell therapies that have been tried in ovarian cancer. In our situation, we have to find a target to attack. And in this situation, it's this protein called B7H3. B7H3 is a protein on the surface of ovarian cancer cells that ovarian cancer cells use to hide from the immune system. It basically tells the immune cells in the body, don't attack me, I'm a good guy. What this CAR T cell therapy does is it modifies the patient's own immune cells to recognize this B7H3 protein and then kill off that cell. And so this is the schema of what happens. Say a patient wants to enroll on the trial. They come in, we extract their T cells. The T cells are modified and expanded. We grow them in the lab. Then when the cells are ready, we bring the patient in, give them chemotherapy to sort of wipe out their own white blood cells because we don't want them to compete with the T cells we give them. After this preparation, we infuse the T cells and then we let them do the work. And so this is a very early trial. We don't really know if it's going to work or not, but this is a nice example of how it could potentially work. This is one of our patients where we've infused these T cells. She had very widely metastatic ovarian cancer, and you can see there's been some response after we gave her this immunotherapy. Okay? This is just a summary of what we talked about today. The importance of PARP inhibitors, these targeted chemotherapies, the antibody drug conjugates, the combination of immunotherapy and chemotherapy, and then these cell therapies we talked about. Thank you very much. On time?
Sorry about that.
No, good. Thank you for...
Questions?
Is there any benefit of PARP inhibitors in non-BRCA associated?
That's a very good question. So a while ago, when the original trials looked at PARP inhibitors, they included all comers, whether you had a BRCA mutation or not. And initially, we felt that there may be a benefit for non-BRCA mutated patients. Over time, what we discovered is unless you have a homologous recombination deficiency, so this genetic scar from BRCA or BRCA-associated protein, it didn't really work. It didn't help. So after a while, the FDA decided and the companies decided to withdraw that indication. So the answer is unless you have a BRCA mutation or a homologous recombination deficiency, it's unlikely that the medications are going to help you.
So do you have any patients who have not had a recurrence but run a CA-125 between 40 and 50 on a regular basis with negative PET scans?
Yeah, I mean, that's definitely possible because CA-125, so what we're talking about is one of the most well-known cancer markers is this protein called CA-125, and this was discovered almost 50 years ago now, and levels are elevated in patients with ovarian cancer. This protein, though, is present on a lot of surfaces inside the abdomen, and there are many non-cancerous conditions that could cause an elevation. So patients who have lung disease, heart disease, liver disease, inflammation can have elevated levels. And everybody's baseline is different. So when we say normal levels, it's you look at different patients' various numbers, and when the majority fall below a certain level, that's what we call the upper limit of normal.
Okay.
But you could still be on that bell curve of patients without cancer and still, and you know, your numbers are maybe a little bit higher, but still for you that's your normal level.
Right.
And so that could be a situation that patients are in.
Right. I was just curious because I've met with Dr. Dorigo a couple times a few years ago, and he said I was like 2% of the population because it's not a common phenomenon.
Yeah, I mean, it's this protein. If you take biopsies from all over your body and you stain for it, you'll find it on different parts of the body.
Oh.
And everybody's level is a little different, and it changes over time.
Right.
You know, levels usually come down over time as you get older, but there are other factors like how well your kidneys are working that really profoundly influence that level. So if you have any level of kidney dysfunction, that number will go up naturally. If you have any patients with heart failure, notoriously that number will go up. Patients with lung disease, that number will go up.
I really enjoyed hearing about the treatment. I'm also super curious about early detection research with the high false negative, high false positive
Yeah.
with the 125. Are there avenues of research being explored?
I didn't address that today. I mean, that's still the tough nut to crack.
Yeah.
Sort of the holy grail of ovarian cancer research is early detection. So people are trying to look at a variety of different ways of detections early. You probably heard about some companies like Grail
Yes.
offering some of their blood tests to look for a variety of different cancers. They look at specific mutational patterns in the blood that would indicate a variety of cancers, whether it's colon cancer, lung cancer, breast cancer, etc. It's still a work in progress. There's some promise there. I have also fielded a lot of questions from patients about using tests that look for circulating tumor DNA. The problem is that that's a very specific test. It's not like I could just look for the cancer DNA in the blood. This test is very specific for every person and each person's specific cancer because it looks at this specific mutational patterns. You can't really use it for early detection. We're relying a lot more on some combination of tumor markers, CA-125 with other things, but that's not been as successful as we'd like it to be. I think the future is probably in tests like Grail potentially for very specific cancers, but I also have examples of cancers that don't shed any of that into the blood. You know, I've had patients where they have a ton of cancer in their body, and even though you look for it in circulation, you don't find it. They don't shed into the blood. So that's one of the downsides to this test.
One more question. For an ovarian cancer with a BACC3 mutation, has there been anything shown the effectiveness? I know there's a whole slew of drugs for breast cancer based on that mutation. Has there been any success or tests in using those drugs specifically for that mutation with ovarian cancer?
Yeah, so you're referring to something called the PIK3CA mutation. That we usually see in more rare ovarian cancers like endometrioid and sometimes clear cell ovarian cancer that are hard to treat. Yeah. Mucinous cancers typically have like KRAS, HER2 mutations, but you can occasionally see PIK3CA because they're associated a lot of the time with endometriosis. You know, the PIK3CA targeting has been very successful in breast cancer because you can combine it with hormonal therapy in particular. And that may work for certain subtypes of ovarian cancer, like endometrioid. but not for others like mucinous or clear cell. So it may be very specific depending on the subtype and whether or not you respond to hormonal therapy. But in general, these inhibitors have not been very successful in ovarian cancer. What we have found is for some of the subtypes like mucinous or clear cell, with these mutations, there may be other pathways that we could exploit, particularly immunotherapy, where the treatments may be more successful.
Can I ask one more question? So you were talking about, well, first of all, I just wanted to say thank you because I was one of the people that got treated for IP.
Yeah.
And it worked. So maybe it was hard for a lot of people, but it worked. So thank you and thank God it worked for me. I wanted to ask you about Elahere. I keep talking a lot in the support groups that I'm a part of about it, and there seems to be so many side effects, especially vision related. So
Yes.
Can you manage that, or what do you do?
So we've gotten a lot better at it. The company has a vested interest in it, in fixing it. So when we initially started with the drug, that was the biggest drawback, is how bad the visions could get. But nowadays, as more and more of our, I would say, ocular specialists, optometrists, ophthalmologists, know about this drug and know about how to manage the toxicity and prevent it, we've gotten a lot better at it. The good news is, I think Elahere is, just like we talk about in Silicon Valley speak, it's like first generation, right? So this is the original iPhone. I was showing Rina-S, which is the next generation of the drugs that target folate receptor alpha, that has no toxicity on the eye because you change the payload. It's the payload that's the problem. But with the next generations of the drug, you can change the payload, change the side effect profile, make it much more tolerable. And so I predict that these eye toxicities will be a thing of the past because we'll move on from Elahere to other drugs. So in breast cancer, for example, they started out with trastuzumab, the Herceptin, and then they did Kadcyla, which is TDM1, and now they have Enhertu, and I'm sure they'll move on.